Hello, and thank you everyone for tuning into the Science Salon podcast. I'm your host, Michael Shermer, and I bring you this show from California once a week as part of the larger mission of the Skeptic Society to promote science and reason and to ensure that sound scientific viewpoints are heard worldwide. As a 501c3 nonprofit, we rely heavily on the ongoing and generous patronage of listeners like you. To pledge your support, please visit our website at skeptic.com/donate. Thank you. My guest this week is Shaili Jain, MD. Her book is The Unspeakable Mind, Stories of Trauma and Healing from the Frontlines of PTSD Science. Dr. Jain is a PTSD specialist and medical director for integrated care at the VA Palo Alto Healthcare System. She is a trauma scientist affiliated with the National Center for Post-Traumatic Stress Disorder and a clinical associate professor affiliated with the Department of Psychiatry and Behavioral Sciences at the Stanford University School of Medicine. Her work has been featured in the New York Times, and her essays and commentary have appeared in the Journal of the American Medical Association, the New England Journal of Medicine, on public radio, and elsewhere. So we get into the book, and I think this is probably one of the more practical podcasts that I've done, given PTSD is a widely recognized and widespread problem, particularly since the war in Afghanistan has been going on for over 17 years now. War in Iraq, a few years less than that. And the category itself, what constitutes PTSD has expanded to recognize the reality of these traumas and what they cause people psychologically. And so it's a huge problem. Many, many millions of people experience this, suffer this. And she's a practicing psychiatrist who works with this in the front lines every day. So the conversation was really, really super interesting about how you diagnose somebody like that, and then more importantly, what do you do about it? So with that, I give you Dr. Shaili Jain. Let's just get right into it.
Okay.
Shaili Jain, thanks for being on the show. Your new book is The Unspeakable Mind, Stories of Trauma and Healing from the Frontlines of PTSD Science. Yours may be the most important book I've had yet on the podcast, in as much as apparently millions of people suffer from PTSD. You're on the front lines of diagnosing and treating this issue. It appears to be much larger than anyone realized just in the last decade or so. But one of the things I like about your book is also, I always appreciate this from authors, is there's a personal touch to it. First of all, the title, you give us what the title means, The Unspeakable Mind, with your epigram from Judith Herman in her book, Trauma and Recovery. The ordinary response to atrocities is to banish them from consciousness. Certain violations of the social compact are too terrible to utter aloud. This is the meaning of the word unspeakable. Mm-hmm. So thanks to your work and that of others, and I think culture's becoming more receptive to it, we are now speaking about this trauma. So start off with your own personal story, where you begin chapter 1 with, of your own background and how this led to you to go into this after medical school.
So I think the seeds for The Unspeakable Mind were probably sown decades before I was born, in the 1947 partition of British India, during the violence that accompanied the partition of British India into India and Pakistan. There was a lot of horrific intercommunal violence, and my paternal grandfather was murdered in that violence. And that was something I'd always known about in my life. And my dad was 10 at the time. So as a result of my grandfather's murder, my dad was orphaned and he lived as a refugee in India. And he was so financially destitute, he was forced to work as a child laborer for a couple of years. So, flash forward 20 years later, my dad would end up moving to England, and that's where I was born and raised. So even though I had always been very separated in geography and time from that tragedy, there was something about that harrowing social descent of what happened in 1947, something about, that those unspeakable events of what happened in 1947 that was still very much present in my childhood, was still palpable, even though we were separated so much in geography and time, like I say, from those events. And so, I ended up becoming a psychiatrist. And so, you could probably argue that on some level, I was just trying to figure some stuff out. It was all percolating in the background. Like, how do people live in the aftermath of the unspeakable? Why do some people seek oblivion? Why do some people seek revenge? And then it was only on a 2000 road trip that I took with my dad. Once I was a psychiatrist and once he was retired and he was able to kind of narrate this cohesive, linear, thoughtful story, that it really came clear to me, oh, okay, these are my people, these are where I am from. And it really kind of led to me thinking about what I was going to do with my career and my platform to help those who have to live after surviving the unspeakable. And that's what led to my work as a PTSD specialist and a trauma scientist. And then ultimately this book.
Right. Beautiful. We often equate PTSD with war victims and rape victims, say. But what you show is that there's a lot of different things that can happen to people in their lives that can lead to at least some of the symptoms of PTSD. After reading your book, I kind of felt like I was born and raised in Disneyland, even though I've kind of had the normal ups and downs. My parents have all died. I had 4 parents, 2 step-parents, and I've gone through a divorce after a 20-year marriage, and that was a miserable experience. But it's nothing like what some people have had to live through. And when you think about the long-term trends in violence in centuries past, we have it pretty good today compared to centuries ago. But on the other hand, there's still a lot of violence in the world.
Sorry.
No, that's it.
And I think what was a surprise for me, one of the first things that I learned when I was studying to be a trauma scientist and doing this fellowship in PTSD, these major traumatic events are actually not uncommon experiences. To me, when I read some of them, rape, combat, surviving a natural disaster, surviving a life-threatening car accident, all these type of horrific things, they felt extraordinary, but they're not. 50% of American men, 60% of American women will at some point report having lived through such a trauma, and there's a subset of Americans who will report multiple such traumas. So there is this kind of weird situation where trauma is a fact of life for millions and millions of Americans. Now, the vast majority will heal naturally. They will not develop PTSD. I'm not saying at all that 50% of Americans have PTSD. That's incorrect. The vast majority will heal naturally, and that's really good. And that's testimony about the resilience of the human brain and how psychologically resilient we are, probably because of centuries of surviving horrible traumas. But a substantial minority will not heal naturally. But because the numbers are so big to begin with, even a substantial minority is a lot of people. Like you say, at any given moment in time, 6 million Americans have got PTSD that needs treatment.
Yeah, when I was writing my chapter on restorative justice in The Moral Arc, I read a bunch of accounts of people that met with the perpetrators. These guys are in jail, and a lot of them were kind of petty crimes, burglary and the person comes home or the burglar's in there. In one case, it was a British guy who confronted the burglar. They got into fisticuffs and so on. And, there was no physical harm, really. The guy got arrested. Now he's in jail. But this guy carried with him for years that 5 minutes of encounter that just really bugged him. Not bugged him. I mean, it just kind of eroded away at his sense of joy of life. It was gone. And it wasn't until he met with the guy and conveyed to him, you just fucked up my life with your little act. And the guy was like, but it was nothing. It was like, it was everything. I mean, to encounter physical violence for just 5 minutes changed this guy's life. And there must be millions of examples like that. You're bullied as a child, or you're battered as a spouse, or even just verbal battering or something. It just kind of chips away at the joy of life. And at some point, and this is the hard problem, at what point does it tip over into something like PTSD, and how would you define it, and from the normal stuff that happens and we kind of get over it?
Well, you bring up a really good point. There's a dose-response relationship with trauma and PTSD. So, a lot of times, people think of PTSD as, someone's living a perfectly normal life, then something terrible happens, and then their life is not good. The reality that I find, though, is oftentimes people have experienced many traumas along the way, and I'm just meeting them at a point in their journey where they happen to have endured the trauma that kind of broke the camel's back. Do you know what I mean? So, I wouldn't be surprised if in the account that you just gave of the person who was burglarized and had those episodes of physical violence, I wouldn't be surprised if there was some past history of something, and this was just that tip, that pushed him over the edge. So dose really matters. So, that explains why our military have higher rates of PTSD, because obviously their occupational exposure involves exposure to trauma. First responders have higher rates of PTSD. Low-income women have higher rates of PTSD. And then youth who are raised in high-crime inner city areas, because they're just exposure to dose is much higher.
Okay, lower socioeconomic women, why? Because their jobs are more physically demanding, or there's more sexual abuse on the job, or
I just don't think they have rights. They don't have a voice. They don't have a platform. So they're easy prey, right?
Right.
If we look at the Me Too movement in the last couple of years, I mean, obviously as a psychiatrist, I can't help but be encouraged by that. But you got to wonder who's going to benefit the most from that. It's people who have a platform, who have a voice, who have a following, who have the resources. I really worry that low-income women who don't have that are not going to be able to benefit from movements the same way.
Yeah, there was a story circulating about after the first couple of Me Too stories came out in the New York Times, Harvey Weinstein, Bill Cosby, a few of the others. They were inundated with calls from like women at McDonald's. My boss keeps harassing me sexually and so on. And they're like, sorry, honey, we can't deal with all these. We have this big celebrities and politicians and CEOs we got to deal with.
Yeah, right. Now, I would hope that it would all trickle down. I think that's generally how movements are. It's usually people who have some kind of status who start a movement because they have that influence. I would hope it would trickle down, but there is so much work to be done to make sure that happens. But yeah, literally, I think throughout history, people who are marginalized, who don't have a voice, they're always going to be more vulnerable to trauma because they're easier to get away with, right? It's easier to get away with traumatizing them.
Right.
It's a sad fact of life.
Yeah. Yep. So I'm a patient. I come to you, and what characteristics would I express that you would, at the end of the consult, say, yep, I think you have PTSD?
So typically a history of trauma, like we just discussed, and those kind of major life events that are life-threatening, they're sudden, the person feels helpless, they feel horrified in the moment, so kind of getting that sense of what their reaction was to the trauma, because that will obviously vary from individual to individual. So definitely listening out for that history of trauma. And then typically the kind of quintessential textbook symptoms of PTSD are really these intrusive symptoms. So they're bothered by intrusive memories of the trauma that kind of are involuntary, vivid, invade their day. They could manifest as full-blown flashbacks where they are reliving the trauma in the moment. They could manifest as nightmares, of the trauma, again, where they're reliving the trauma in their sleep. The exaggerated startle reaction, they just see danger everywhere. They're just quick to kind of freak out and feel unsafe. Those are like your textbook symptoms. I think what often gets missed is the toll PTSD takes on one's emotional life. It renders emotional lives barren. People, they don't love as freely. They don't live as freely. They live life often on in a very constricted way, to kind of protect themselves from being hurt again. And that impacts the way they love, the way they work, the way they play. So it really chips away at life in an insidious way. I think that's what gets missed. And definitely the mood states of like shame and guilt, which are harder to identify than say like anger or depression. Those get missed a lot. And I think those are key in trauma. Shame and guilt are very pivotal emotions in trauma.
Guilt as in survival guilt. Why didn't I die and my buddies did?
Oftentimes survivor guilt is huge. And then even guilt, even if you talk about family violence, right? A lot of children who were raised in environments where family violence was a fact of life, a daily fact of life, they're very conflicted. They feel guilt. They feel an allegiance to these people who raised them and who at times may have been loving or may have supported them, but yet very conflicted about how they should feel in response to the violence and the shame they felt at being, abused or victimized in that way. So guilt is really this kind of perpetual theme.
By the time you engage with somebody, they're having problems in their life. That's why they're coming to see you in the first place. it's interfering with their job or marriage or whatever. So it really, the tipping point for you would really be on that spectrum. It would be if it interferes with your life to the point where you feel you need help, that would be a definition of PTSD.
Yeah, and that's actually integral to the diagnosis in the DSM-5. It's not sufficient that you have symptoms. These symptoms have to have been present for a significant amount of time, plus they've thoroughly disrupted the way you live your life. And that's what you're kind of listening out for. So oftentimes, like you said, people don't necessarily come in to see me saying that they have nightmares, but they do come in saying my wife is about to leave me because she's had enough.
Right.
Or, I'm getting ridden up at work for performance issues. Like they get hit really hard at the kind of day-to-day functions that you or I might take for granted. And that's when you get a sense, okay, this has slipped into beyond normal adaptation or just regular life. This has slipped into what we consider to be in the realm of pathology.
A little bit like alcoholism or drug abuse. How do you know when you have a problem? Well, when your spouse leaves you, you get fired, right. Then you know you have a problem. Interference with normal life functioning. As a practical matter, let's say, given our messed up healthcare system, if I'm on an HMO of Kaiser or Blue Shield or whatever, and I feel like I need help, who would I even call and ask? Just do I have to go to a GP and then he gives me a referral to a psychiatrist, and then the psychiatrist gives me a referral to a PTSD specialist, something like that?
So I think I always tell people start with the regular doctor who knows you the best. Your internist or your GP who you may have had a relationship with for years. Go see them first. As much as I love talking about the symptoms of PTSD, the reality is you still need a healthcare professional to diagnose it. So you really want to have that conversation with a healthcare professional who can just make sure that that's what it is and there's not other stuff going on that needs to be ruled out or, like blood tests or something else that needs to be addressed. Start there if you're lucky enough to have that kind of relationship. And the good news about going to a trusted doctor is they probably already work with mental health professionals with these type of things. And so they're referring you to somebody they trust and they have that kind of relationship with that they can communicate with. And that's really where it starts. Unfortunately, we don't have a lot of PTSD specialists. We have a lot of mental health professionals. PTSD specialists is still really tiny. But the good news is a well-trained mental health professional will definitely be able to make a good start in terms of offering treatment and helping alleviate some of the symptoms.
You have 2 chapters on the brain and the body. Walk us through what happens when you encounter trauma. Again, a war trauma or rape or violence of some kind. What happens in your brain? Neural networks are rewired or something, or brain chemistry? What happens to your body with all those stress hormones? And why does it continue, and why do some people, their brain doesn't get rewired, and others it does?
Okay, so...
The big questions.
Yeah, I was going to say, so I'll talk a little bit about the neurobiology of PTSD. I'm happy to summarize what we know, but I'll do it with the caveat that this is constantly shifting this landscape. The minute I almost tell you what it is, someone... So again, that's just the way neuroscience is constantly shifting as we get better ways to probe the neurocircuitry and better ways to investigate. But in essence, I think it's safe to say that in the PTSD brain, something is probably up with the hippocampus, which is the part of the brain where we store memories, long-term memories. We know it's smaller in people who have PTSD. We don't know why or when it became smaller. We don't know if they were born with a smaller hippocampus or if being exposed to PTSD somehow shrunk the hippocampus. We don't know, but there's something going on with the hippocampus. And then there's 2 parts of the brain. There's the amygdala, this primitive part of your brain that regulates fear and pleasure and anger. That's overactive in people who have PTSD. They just tend to not only detect danger where danger doesn't exist, but even their response is an exaggerated response. So, your typical example would be road rage, right? That's a classic symptom that people with PTSD often have. They have a really disproportionate reaction to being cut off on the road. Right. And it takes them a long time to calm down. So the amygdala is overactive. And then at the same time, your frontal lobe, the part of your brain that is so integral in execution and judgment and planning, that is underactive. Right? So if you combine this overactive amygdala with the underactive frontal lobe, you can see why you start to have some of these issues with recklessness or anger or hypervigilance that people with PTSD complain of. So in terms of kind of neurobiology and structurally, that's what's going on. In terms of chemistry, we definitely know noradrenaline, adrenaline, those chemicals that we need for your fight and flight reaction. We need that as human beings. We need to be able to mount a fight or flight reaction when we're under threat. But there's something about that response in people with PTSD. It doesn't come back down again to baseline. So they have higher levels of noradrenaline and adrenaline circulating in their bloodstream. There's definitely something up with the human stress hormone cortisol. We don't know exactly. It's a very complicated picture, but definitely that is implicated in the pathogenesis of PTSD. And then serotonin too. We know there's serotonergic dysfunction, and that probably contributes to a lot of the mood issues that I mentioned earlier. So those are some of the clues of what goes on in someone's brain and body when they have PTSD.
I can feel it when I get angry, or I'm super stressed out. I can feel the stress hormones pumping through my body. Not just a faster heart rate, but it just feels differently, and I can only imagine. I mean, I get over it, a couple hours later, everything's fine. But I can only imagine being in a war situation or something where this is just constant, day after day for months and years. And you multiply that by 100,000 or several 100,000 soldiers, regardless of which way the causal arrow goes, even if it's like 10% of that 100,000 that are born with a smaller hippocampus and they just don't respond as well to that others. Either way, you get that much trauma, it's just got to take some kind of toll on your physical body.
Oh, yeah, absolutely. So we know now that PTSD is an independent risk factor for heart disease. Because obviously having all those chemicals at higher levels in your body for extended amounts of time, that's not healthy. That impacts disease. It causes disease in cells, bodily systems, organs. So we know people who have PTSD are higher risk for heart disease, cancer, obesity, you name it. So, this kind of false dichotomy between mind and body, in my mind, it's false. It's definitely a whole bodily system condition.
I can't remember if you cover the opioid crisis in your book, if there's any relationship between that and PTSD. Are people self-medicating with long-term pain-killing drugs?
Well, we definitely know PTSD and addiction go hand in hand. Very tight relationship between those two. And as you said, part of it is because of the self-medication, the allure of self-medication to relieve some of these symptoms. But then oftentimes that use of substances just becomes a full-blown addiction in of itself. And then the PTSD becomes very hard to treat. In terms of the opioid crisis, there are a couple of big data studies that took a very bird's eye view, and they looked at people who are prescribed opioid pain pills for chronic pain, because there's a big overlap between chronic pain and PTSD. Something like 35% of chronic pain patients have got PTSD.
Wow.
So there was a study that looked at people who had PTSD, chronic pain, and had opioids prescribed to them versus people who just had chronic pain and opioids. The group that had the PTSD, they were much more likely to run into side effects with the meds, like accidental overdoses or intentional overdoses, or falls, or getting into problems with the meds. And so in my mind, the take-home message there is, if people are using prescription opioids to treat emotional or psychological discomfort, we're going to run into problems when actually what they need is treatment for that psychological condition.
Yeah, but guy comes back from war, he's got injuries or whatever, and he goes to his doc, I'm in chronic pain, here's some hydrocodone or one of the opioid derivatives, and he feels better. Yeah. Now, I get this because I had a total hip replacement, so they gave me hydrocodone for this for, 2 months or whatever. And then recently I got a tooth thing, and they gave me a 1 month thing. It's not just that it knocks the pain back. I feel way better, like energized, happier, and just more engaged with people. And I thought, holy crap, I could just go for this like every day for the rest of my life, and I get more work done. What's the problem? At some point, the dose they're giving me is just not going to do it, so I'm going to want more.
Absolutely. You're going to build a tolerance to it. So you're basically describing like some euphoric effects of being on the medication. In addition to the pain, it's knocking out your pain, but there's some additional, psychological enhancement. And that's the problem. You're going to need more and more of it. And then, of course, these meds come with side effects. You're going to develop side effects, tolerance. You're going to need more and more. And then you're going to start using it even when you no longer have pain. And you can see how quickly this could get out of control, especially if you have a psychological condition that is causing you suffering and you really want relief from that. I mean, it is a really, really tricky situation. And I think pivotal to it is clinicians just being hyper vigilant about this.
Right.
We're not going to withhold pain medicine from people who are in pain, but, not everybody needs a month's supply.
Right.
I mean, people have been too liberal in how much they dish out.
But you'll be glad to know my doc said, no, Shermer, we're not giving you any more because your hip is fine. I'm like, oh, darn. Okay.
But right. And that is a 2019 response or a recent response. But,
Right.
the history of this kind of epidemic has shown that that's not always been the response. But luckily things are shifting in a better direction. But yeah, I always worry about addiction with my patients who are living with PTSD. It's just part and parcel of the territory.
Right. Now, one of the tragic symptoms of PTSD is suicide. So why are these people killing themselves? It's to remove the pain, or is there some other motive?
So I think just the very nature of living with mental health condition, the vast majority of people who have a mental illness, they're just higher odds of dying by suicide, period. It's like people who have heart disease, they're higher risk of dying from a heart attack. It just comes with the territory. So part of it is just that elevated risk. I think we know a little bit better about the profile of people with PTSD who are more likely to commit suicide. So for example, people who have a lot of those kind of activated symptoms, the hypervigilance, the anger, they're more likely to commit suicide. If people have other injuries, so for example, let's say if somebody survived a bomb blast, and in addition to having PTSD from the bomb blast, they also have a brain injury, they're more likely, they're at higher risk because now they're dealing with PTSD, but they're dealing with a brain that isn't working that well.
Right.
And then I think man-made crimes, human-made crimes are always much more potent to recover from than, say, a natural disaster. There's something where humans are wired. If it's a natural disaster, if it's an act of God, we can somehow let go of it more than if another human intentionally set out to harm us. And then back to that guilt and that shame, I think survivor guilt is huge in terms of the reason. And then shame, if people felt they should have behaved a certain way, but they didn't, if they feel they let themselves down, if there was some kind of moral, or philosophical injury.
I wonder if there's something in our evolved moral emotions where an earthquake or natural disaster feels more random, whereas somebody did something to me and I should dial up my paranoia about other people so that doesn't happen again. And so maybe this happens to you and I once or twice, but to the war veteran or whatever sexual abuse victim, it's happened so many times, they've just hit the point where the rational decision is, I don't trust anybody.
Yep. Oh, happens all the time. This kind of exaggerated cognitive reaction, that, okay, I don't trust anybody. But here you go. The problem is this social isolation, this emotional alienation. That in itself is such a problem, right? I mean, humans, we're wired to be social beings.
Right.
So if we cut ourselves off from the world like that, you set yourself up for so many other complicated psychological symptoms. So it really is this dilemma for the trauma survivor. And that's why early intervention and treatment is key before those thoughts take hold, and become entrenched.
So
Getting
to the spouse that says, but darling, I love you. I'm not one of the bad people. They're approaching it like it's a rational thing you can talk somebody out of, but it's not that simple.
Not at all. And the statistics show if you love someone with PTSD, the odds of you yourself developing PTSD, depression, or anxiety go up.
Oh, wow.
People who are living with PTSD, they're much more likely to be divorced, multiple times.
Right.
They're much more likely to have problems not only with emotional intimacy, but sexual intimacy too. So it wreaks havoc.
You mean the spouse married to the PTSD victim gets divorced and gets remarried and carries some of that with them into their second marriage, and therefore they're more likely to get divorced?
Oh, sorry, no, I should clarify. The person living with PTSD, they themselves are much more likely to be divorced.
Oh, right. Okay.
Yeah. And they are probably more likely to have issues with emotional intimacy or sexual intimacy, which contribute to the demise of the marriage.
Oh, wow. Right. Okay.
Yeah. But at the same time, trauma is infectious. So I think spouses who've been in long-term marriages with people who've got PTSD, it's rare that they're going to escape unscathed themselves. And they probably are going to take baggage to future relationships as well. So it's both.
And what do we know about the children of PTSD victims?
Yeah, the same. Families are impacted, Now, what's really fascinating is, and we haven't really touched on it, and it's definitely worth mentioning, is this whole theory of kind of epigenetics and
Yeah.
intergenerational transmission of trauma, because there is some early work done. It's still in its infancy, but definitely worth mentioning this notion that if somebody has been exposed to a very major trauma, it impacts, if it's a man, it impacts their sperm. If it's a woman, it impacts her eggs in a way that is an adverse impact. And then those changes are transmitted to any subsequent children via this process of intergenerational transmission.
Yeah.
So these children literally carry these changes and these vulnerabilities in their blood, altered neurochemistry, altered neurobiology. So even if these kids themselves have never been exposed to a traumatic event, if at some point in their life they are, they're going to respond with that inherited kind of vulnerability. So, when we think of mass traumatization, when we think of torture, genocide, slavery, you can really start to get an impact of this deep footprint that PTSD can leave.
Yeah, I've seen these epigenetic studies brought up in other books dealing with civil wars and terrorism and things like that. I'm always a little skeptical because we don't know the exact mechanism of how that would change the gametes. And also the social learning people say, well, but if you're raised in a family where there's PTSD, surely there's a huge environmental effect as well.
Yeah, absolutely. And that was the conventional wisdom up about 20 years ago. That was the conventional wisdom that if you're raised by someone who has PTSD, that is going to alter your worldview. That's going to impact you in a negative way, how you navigate the world yourself psychologically. But a couple of the studies that have come out, and most notably, I'm talking about the work of Rachel Yehuda from Mount Sinai, they've started to delineate a little bit and separate out those social factors by using the marker cortisol.
Oh, right. Cortisol.
Yeah. So there's a little bit of work. Like I said, early days, it's a very, very complicated thing to try and figure out. But there's enough there that we should be curious, that there's more than just the social environmental learning. There's something almost biological too.
Give us a quick history, which you do in one of your chapters, on why it took so long for us to recognize this, given that in the Civil War and the First World War, it was clear shell shock, and a lot of these guys were totally messed up. So we knew about this, but it didn't get interpreted correctly.
So the history of PTSD is once the war's over, everybody forgets about it.
Right.
So that's basically what happened after World War I, World War II, the Civil War. Like everybody gets very, very interested because I think countries and whole governments, there's a political incentive to be interested. And then unfortunately after the wars, it just languishes. The field just languishes. And it was only in the 1970s after the Vietnam War. And really through an act of advocacy on the part of Vietnam veterans who were like, this is a thing and we need to pay attention to it. And then there was a lot of women's rights organizations that were advocating on behalf of victims of, domestic violence. And then there were shifts in changes to the law that protected the rights of the victim. And then I think we were able to get over that hoop and not forget about PTSD. But it didn't enter the official diagnostic nomenclature till 1980, which is really insane if you think about, this is a condition that's been described in ancient texts, in Greek texts, and it goes back through the millennia. Freud talked about it, Jung talked about it hundreds of years ago. 1980 is when it was officially recognized. So in many ways, it's a very young diagnosis. It's like 40 years old.
Yeah, probably still suffering from this idea, this mismatch between if you have a medical condition, people are more sympathetic and we're going to treat it with some physical thing. Whereas if you have a mental disorder, just get over it.
Yeah.
Get
over it. Pull yourself together.
Yeah, pull yourself together. And it's, but now we know enough about neurochemistry that there's really no difference. Medical models, mental or physical, really they're the same.
Well, yeah, and I like to, in my heart, I'm a clinician. That's what I was trained to be. That's still what I do. And I'm like, you know what? Even if I can't see physically what's going on with you, I can see suffering.
Right.
People don't make it up. I can see suffering, and the wounds might be invisible, but to the trained eye, you can see the consequences of those wounds.
Right.
So I think people have suffered unnecessarily. They have been overlooked. And I should add, I think part of the reason PTSD was so late to be accepted is there's a societal collusion too. We don't want to see trauma either. It's not just the individual for whom it is unspeakable. For society, it is too, because it asks some very difficult questions. If someone was traumatized, then that means there's a perpetrator. And how do we feel about that? And what stance do we take? It puts us in a really difficult bystander situation. So there was a collusion. Society didn't want to see it too.
Yeah, I think governments are not too inclined to recognize this because it's another cost of war that they have to justify. Here we are in Afghanistan, 17 and a half years later, still going. I was trying to remember the name of it was Coming Home, I think, the Jane Fonda, John Voight movie about Vietnam. I think that was in the 80s. And I think that now looking back on it, that was kind of a PTSD recognition film because at the end of the film, the other guy, I forget the actor's name, that was her love interest. The film ends with him walking out and he takes all his clothes off, walks out in the ocean and kills himself. Yeah, I don't know if you ever saw that movie. It's I think that was one of the first to recognize in the Vietnam War that there was something like what we would now call PTSD. Yeah, coming home.
Right.
All right, so I've just got my consult with you, and it's clear I have a PTSD problem. I say, Doc, what do I do?
So if you want to look at the best data we have of what is most effective to help with symptoms, you definitely want to start with a talk therapy, some kind of psychological talk therapy, something from that overarching banner of CBT, cognitive behavioral therapy. And there are many therapies that kind of come under that banner. And so you can take your pick, things like prolonged exposure, cognitive processing therapy, EMDR comes under that banner. And I think, in essence, we've never really done the dismantling studies to really prove what is the secret sauce. But I think, in essence, what is the secret sauce to a lot of effective trauma-focused psychotherapies? The exposure is key, the exposure element, and then the cognitive restructuring. And then also just the basic psychoeducation. Just telling somebody what PTSD is and what it does to your brain and body can yield amazing results. Just explaining to somebody and then equipping them with tools like relaxation or breathing retraining or mindfulness. Those type of things can be very helpful. So I think those are some of the secret sauce ingredients that contribute to those psychotherapies being effective.
Meditation?
Yeah. So meditation is definitely of interest. There's a lot of focus on things like meditation, yoga, massage, acupuncture. Those all come under the kind of mind-body treatments that are not, the data to support their effectiveness isn't as robust as what it is for the CBTs. I'm not saying it doesn't work, but the data is not as robust. Definitely as an adjunct, I think it can be very useful. I don't know if standalone treatments, if we have the data to support their use of standalone treatments. But, so my approach when I diagnose someone with PTSD is I think we should try what is tried and tested first. And we should work our way through. And then if those aren't effective or if you're not getting optimal results, then let's try stuff that's not as tried or tested, but is still nonetheless popular, or that we have anecdotal, evidence that it might be helpful.
So if I'm getting thought flooding maybe 20 times a day, every hour, say, of the trauma, and it just keeps coming up in my head, what do I do to get rid of that or knock it back to half of that or whatever?
Yeah, it's hard work. A big part of it is helping the person recognize what their trauma triggers might be. Oftentimes, those intrusive symptoms that you describe, there's triggers that sets the brain off to trigger that intrusive experience. But the survivor oftentimes doesn't know what those triggers are. It takes a while to connect the dots, and that's what a really skilled therapist can help you do. So it might be a particular smell or a sound, or a feeling. But until you go back to the trauma and really dissect it and take it apart, you're not going to recognize what your triggers are. But once you know what your triggers are, I tell people you're back in the driver's seat again. You might still have the intrusive symptoms, but at least you see them coming because you know what your triggers are and you have a bit more control in that situation. And that in itself can be incredibly helpful in reducing the severity of the symptoms. I don't think these symptoms ever go away in their entirety. But, if you can go from having intrusive memories, 10 times a day to twice a day, that's something, I
remember in the Me Too, one of the Me Too stories was a certain cologne that the rapist or, the perpetrator wore then was a trigger for this woman's thought flooding of the trauma. Now, how would you deal? I mean, just exposure to that cologne smell without the trauma would attenuate the reconnecting of it to the trauma, or how would that work?
Yeah, I guess that would be one way of going about it, a very thorough way of dealing with it. But again, just making that connection, just helping the person make that connection, because otherwise sometimes, let's say this woman ends up sitting next to a colleague at work who has the same cologne. If she doesn't know that that cologne is a trigger for her, she may just suddenly feel very flooded, very anxious, very panicky, and need to leave the room. But sometimes I think just knowing, oh, okay, that's why I'm feeling uncomfortable, you can kind of nip things in the bud. But yeah, you're right. I mean, if you really wanted to go deep, you could actually do like an in vivo exposure exercise to actually desensitize it to the smell of the cologne. Yeah, theoretically.
Like what people do, they go to CBT for, say, snake phobias or
Yes,
spider phobias or something like that.
Yeah.
But it's interesting that just being aware that there's a problem, other people have it, here are a bunch of the causes, somehow gives people, maybe it's a sort of internal locus of control. Like, okay, this is something I am now aware of, so I have some control over it, rather than it feel like random assaults on me.
Yeah, I think it does. And I know it sounds really simple, but that kind of name it to tame it philosophy, I can't tell you how many times in my office I'll have an interaction conversation with a patient and they have that light bulb moment where they're like, oh, okay, I get it. I get it why suddenly I have road rage or why I can't stand to be around certain people in certain situations. And it's really reassuring. Giving someone a name for what they're experiencing is really reassuring. Now, the sad fact is, because of lack of access to mental health care in our country and the fact that we don't have enough funding for mental health care and we don't have enough mental health professionals, there's a lot of people who aren't even going to get that conversation. They're not going to get a personalized conversation.
Yeah, offline, I wanted to talk about the Robert Rosenhan study, David Rosenhan study. We don't have to talk about that, but it's interesting. When that was done in the 70s, the mental health system was far more inclusive. It was easier to get into a mental hospital and pretend to be a patient and then try to get out. Yeah. Okay, so that was an interesting study in how we diagnose things. Things were certainly different then. But after Reagan emptied the mental institutes, and now we have most of them homeless on the street. This itself is a problem, and I'm sure you must encounter this. A lot of PTSD victims probably end up homeless because they lose their jobs and families and houses and so on. Just comment on that in general. What's happened over the last, say, half century in our healthcare system of dealing with mental issues like that?
So, to me, it feels like mental health is stigmatized beyond belief to a point. I mean, it's irrational for me to comprehend. So today, I used to be a hospitalist before I became a trauma scientist and PTSD specialist. I was a hospitalist, which meant all my work was in an inpatient hospital. And a big chunk of my day was spent arguing with insurance companies for why my patient needed an extra day in the hospital. And these are people who've been paying insurance premiums their whole life. These are people who are suicidal, they're homicidal, they're psychotic. A lot of people with regular PTSD wouldn't even end up in the hospital today. They don't meet criteria. There's very strict criteria that people are allowed to end up in the hospital with to begin with. And then on top of that, we have to fight. It is the mental health parity issues. In my mind, it's a social justice issue. Like I mentioned to you, the burden on family members is incredible. It's just getting shifted onto family members who then are left to care with people who are still pretty sick. And who could benefit. And then again, the socially disadvantaged are the most hard hit because they can't afford, to pay out of pocket or afford big copays. And then starts this cycle of social decline. They start to lose jobs, then they lose insurance, then they lose their home. And then the fact that they're homeless makes them vulnerable to being traumatized anyway, right? So just these cycles that people can't get out of. And it's really distressing for me.
So for the insurance company, it's just money. It's a business. And the sooner you can get them out and the shorter the stays, the more money we make.
Yeah, absolutely. Because there's less money coming out of that pot. And, as a physician, I'm the one who's taking care of this patient. I'm taking responsibility for this patient ethically, legally, whatever. But yet there's another person in an office in a different state who gets to tell me what to do. I think for a lot of physicians, it contributes to a lot of burnout because you just feel like you can't get your patients what they need.
Right.
And we're not talking about luxurious care here. We're not talking about 30-day stays in spa-like settings. We're talking about literally keeping people safe.
Right.
So, I think there's a time limit on how long someone can be a hospitalist. So I did it for a good few years. But yeah, it's just really distressing to me. And there's just something about this rhetoric that somehow mental illness is not real illness that is so stigmatizing.
Still.
Getting better in some ways, like the fact that I can write this book, the fact that I can have this conversation with you is an encouraging sign of progress, but probably not fast enough given the burden of mental illness, given the societal burden and not just psychological, but economical. I just don't understand why we still have to have these stigmatizing responses.
Yeah, my wife's from Germany, and they have universal health care there, and they just don't have any of the issues we have. They pay a little more in taxes, I guess, yes, probably, but it isn't burdensome. They still have a incredibly vibrant economy. It's the strongest in all of Europe, entire EU. So what's the problem? Our system is so politicized. My first encounter with what you just described was my mom fought meningioma brain tumors for about a decade. And so we were trying this and that treatments. She had 5 craniometries, 5 radiation helmet treatments and the whole thing. And they finally just said, it just keeps coming back. There's nothing we could do. So I tried this experimental drug and it made her dizzy and she fell and hit her head. It was in a coma. So we went to the Huntington Hospital in Pasadena there and they took great care of her. And then, never forget this whoever the administrator comes in to talk to me and my dad, and says, well, this is going to seem really cold, but you have to take your mom out of here by 5 o'clock today. And we're like, she's in a coma. What are you talking about? Beds up. We got new patients to come in. This is what it costs us per day to keep your mom here. You got to move her to a place that's cheaper. And we're like, holy crap, what? And we had great healthcare system. My dad had plenty of money. It was not an issue, but it's like, holy shit. What if we were dirt poor and had and we'd be fucked. I mean, anyway, I was like, oh man, this is messed up. And that was 20 years ago. So, wow.
So distressing. Yeah, so distressing. And I still feel like, if people can advocate for themselves, you might be able to make an argument but people who don't have advocacy skills, who aren't educated, don't have a platform, it's really distressing to see what happens to people who fall through the cracks of the healthcare system.
Yeah. That has to change. I don't know how to change it. If I was running for office, I wouldn't know what the answer is other than just universal health care and let's just get over it, bite the bullet. But yeah, so how many people, what's the estimate now? What percentage of the American population or elsewhere have PTSD?
So I think the 2 to 3% in terms of over like a lifetime prevalence. So it just depends what statistics you're using. But at any moment in time, that translates to about 6 million with active symptoms that need treatment. Now, we know there is this condition called partial PTSD, which doesn't meet the textbook criteria, but has a kind of muted form of PTSD. There's many, many millions more who have partial PTSD, and they probably need some form of help. It's like having pre-diabetes. You don't have the full-blown thing, but that doesn't mean you're not at risk. So collectively, you can start to get a sense of how many people we're talking about. And then the fact that PTSD goes hand in hand a lot of times with depression, anxiety, substance abuse, the fact that it's infectious, that it impacts family members, you can start to get a sense.
Do you ever write prescriptions for SSRIs, antidepressants, anti-anxiety medications for PTSD?
So a lot of times when people come to see someone like me, because I'm a psychiatrist and I kind of get pigeonholed into that medication management role, that's what they're coming for, because they've maybe tried a psychotherapy and it has not worked, or they don't want to engage in psychotherapy for many, many reasons. And so oftentimes that's who gets referred to me. And then in terms of evidence for what works in terms of medications, I think SSRIs, SNRIs are probably the meds that we have enough data for to support their effectiveness in PTSD. So definitely a trial of that is certainly warranted for many people, especially if they have comorbid depression or if they've been suicidal or, they've just got that more severe form.
Yeah. I think you're also encountering, in addition to the sort of ignorance of mental illness issue, it's not like a physical illness. this kind of postmodernism, psychiatry is not a real science. When we first started Skeptic, people were sending me stuff from Thomas Szasz. Like, you got to read Szasz, Shermer. He's a skeptic like you, and you should be skeptical of mental illness. There's no such thing. It's all socially constructed. And then I read Foucault's book. I forget the title of it, but basically mental illness was invented in 1581 or whatever. And that, if you think your kid has ADHD, he doesn't really. He's just active. And 200 years ago, he would not have been diagnosed with ADHD. He would just be working on the farm, being active or something. You know the arguments, right?
Yeah.
To me, I just can't see it. I can't go that far. I mean, I can see where there's society defines things a certain way. Yes, there's always a cultural influence. But with something like PTSD, schizophrenia, any of the extreme psychoses, there's obviously a brain chemistry thing going on. It cannot be just pure culture.
Mm-hmm. Yeah, I don't know. I'm always a bit befuddled by arguments like that. When I was a medical student and I was choosing what specialty to go into, people were very surprised when I was interested in psychiatry, and mentors were actively getting me to change my mind, and their responses were really stigmatized responses. So if you imagine, there's that stigma coming from within the medical profession.
Wow.
And I just never understood it. And the only conclusion I could come to is that these physicians who were literally saying to me, you'll be weird, you'll be a weird doctor if you become a psychiatrist, literally, I think it's just this discomfort with emotional suffering, psychological suffering, and extreme discomfort. And so I think if that type of stigma comes from within the profession, I'm not that surprised at the arguments from without the profession. Here's the thing, in my mind, I think you have to be comfortable with a certain duality if you're going to be a psychiatrist. PTSD is probably overdiagnosed, but it's also simultaneously underdiagnosed. You have to be comfortable with holding those two opposing thoughts in your mind. The very nature of mental illness, the way we diagnose it, it is open to misinterpretation. It is far from a perfect classification system. I'll be the first one to say that. But that doesn't mean we stop trying. I feel like we're getting better. So if you look even in the history of just PTSD alone, we have a lot more diagnostic tools and screening measures so that we're a lot more precise about diagnosing PTSD than we say it was 40 years ago. Is it perfect? No. But in my mind, that doesn't mean we stop trying or that we throw out what we've done.
Right.
We just carry on refining. This is the brain at the end of the day. This is human beings, infinitely complex. So in my mind, this is a good battle worth fighting, and we keep on moving forward. But yeah, it's overdiagnosed, but it gets missed all the time as well. So, I don't see the value in just focusing on the bit that it's overdiagnosed until you correct for the other as well.
So the DSM 4R or 5 or whatever we're up to now, it's 5, right? I think.
5, yeah.
So obviously PTSD is covered in that fairly extensively, I presume. Maybe what it needs to be is in whatever the equivalent of that book would be for regular medical non-psychiatry students, something like that, where they have to take a course in a bunch of these obviously medically based mental disorders that aren't part of this branch you're in of psychiatry, but it's just a larger part of medicine. Maybe something
so
like that.
The ICD-10 covers all those diagnoses.
They do? Okay.
Which they do, but the problem is it's a curious thing, American medical education. Like I went to medical school in England, and it's a curious thing. The average medical student in America is not exposed to that much psychiatry. They might have a month of psychiatry in their whole medical school.
A month?
Yeah, the average medical student. So let's say tomorrow's surgeon or tomorrow's dermatologist or tomorrow's, internist. And so herein lies the problem, because you know what? As a psychiatrist, I may or may not meet someone who has a brain tumor. I may or may not meet someone who has psoriasis. But I bet you as a dermatologist or as a surgeon, you're going to meet someone who has a mental health disorder. Right? Because they're very prevalent. Right. 1 in 3 people will have some type of mental health disorder.
Right.
So to me, I feel like it's an educational issue. They're just not getting enough exposure. So then I think they're not comfortable with it. And then when they're not comfortable with it, a natural reaction is just not to do anything about it. Right. To ignore it. Like if they haven't got mastery of it, they don't want to admit it. But I got to say, things are getting better. I do feel there is more attention to psychiatry in the training of medical students, but it's just not enough. Whereas in England, because most doctors are going to end up being GPs in the National Health Service, they have to have extensive psychiatric training. They have to, because it's a population-based model as opposed to an individual-based model. So you have to meet the needs of your population. So Yeah, it's tough, but yeah, it would definitely help if people within the profession had a bit more awareness.
Yeah, and the consequences are going to go on. I mean, this whenever the Afghan war ends, if it ever does, you're talking maybe another 50 years of consequences
Yep.
from your perspective on PTSD of
Yep.
those soldiers and their spouses and then their children.
Yep. And I feel like I want to be optimistic too, because I do think those numbers might not have been that different in years before, but we just ignored it.
Right.
You know,
Right.
so I think the fact that we're giving it a name, we're being a bit more bold and stepping up and identifying the problem, and also the fact that 30, 40 years ago, PTSD was considered incurable, untreatable.
Mm.
Today, it's very manageable and very treatable. It's not disabling. This is good news, and there should be reason for hope. And I see it already. I see it already in veterans who come back and who get treatment really early. They do really well if they can get early intervention, as opposed to waiting the average 12 years that
Right.
people wait before they get help. Because I think it's out there more in the zeitgeist, so people are that little bit more open to getting help. So I feel like it shouldn't be doom and gloom. There should be hope here too, that we're becoming a more trauma conscious, more trauma informed society, that we're even allowing it to exist and accepting its existence.
There was a 60 Minutes piece a few weeks ago. You probably saw it. I forget, they were injecting something in the guy's neck that was supposed to go right into the amygdala or something like that. I forget what that is, though.
So they were doing a blockade of the ganglion of the
that's what it
nerve
was.
cluster.
Right.
So basically, that fight or flight that I was telling you about that is out of control in people who have PTSD, by injecting the kind of cluster of nerve cells with an anesthetic, the idea is that fight flight response will come right down. And so then people are better able to engage in therapies or day-to-day life and avail themselves of treatments. So it's experimental. What they showed on the 60 Minutes show was experimental. It's not routinely used yet. We don't have that level of data that we like to see, the kind of randomized control placebo trials that we like to see to make sure that this isn't just a placebo response. So yeah, I mean, obviously anything that offers relief, we're all interested in it. I just have a caveat, and I talk about it in the book. I've been a doctor for 20 years now. I've been through a lot of these cycles where these kind of magic bullets come along, these things that get a lot of media attention because they just promise this instant relief.
Right.
And I've been through a lot of cycles of these with patients, because patients are naturally drawn to these because they're suffering and they want relief. But then unfortunately, sometimes these things don't end up panning out, and they overpromise and underdeliver. And then I kind of have to live through these cycles with patients. And then patients are setting aside true and tried and tested treatments for kind of these magic bullet options, and then we lose ground. So I feel like I'm a bit of a skeptic, to tell the honest truth. And I always keep my ear out. I always want to know what's going on, but I feel like it should meet a criteria of evidence before I'm going to even present it as an option.
Yeah.
So I think it's my job to kind of keep focus and keep objective.
Yeah, it's always difficult to know what to do with anomalies like these one-off events that seem like they're going to change the entire science. And everybody says, oh, you're closed-minded, Shermer, for not being open-minded to this. It's like, well, I'm old enough to know that I've seen this happen over and over and over and over, and almost nothing comes of any of these.
Yep.
The cure for cancer is right around the corner, and so on and so forth.
Yep.
Yeah, it would be nice if the problem is, I think, it's just the human body and brain is just so complex that there's not going to be a single bullet. It just can't be.
The idea of a magic bullet solution for PTSD, to me, it just doesn't feel like that's a realistic approach.
Right.
The problem is, though, with a lot of these magic bullet stories in the 21st century, the hubris remains on the internet.
Oh.
So then now, I still have people coming to me asking about XYZ, even though it had been proven to not be effective. But the problem is that when it's not effective, that doesn't get as much media coverage.
Right. Well, it's a little bit like the anti-vaxxers still hanging on to that one study done by Wakefield back in 1996. Since refuted, debunked, retracted, declared fraudulent, and so on. It just hangs on there.
I know.
Yeah, that's really difficult. I wanted to ask you about another issue we dealt with in the 90s at Skeptic was repressed/recovered memories, which were then thought to be sort of confabulated or constructed memories that weren't really in existence. I asked because a lot of them were associated with childhood sexual abuse. So these are mostly adult women who had gone to therapists in their 20s or 30s with whatever symptoms, weight loss or gain, sleep problems, depression, and so on. And a handful of these therapists said, well, these are symptoms of being sexually abused as a child. Well, I have no memory of this. That's because people that are traumatized often repress their memories, and we have to coax them out through techniques of talking and hypnosis or whatever. Now that, as far as I know, has been fairly thoroughly debunked, mainly by other victims of trauma who said repressing memory is not the problem. I can't stop thinking about it. Holocaust victims and war victims and so on. Anyway, I don't know if you read much about that whole issue, and it does get down to the core of memory. To what extent can we forget things and repress things and bring them back, or do we just forget them for a while and they're brought back through a trigger or something like that?
I think that whole chapter was an unfortunate chapter in the history of PTSD, and it probably set us back a lot. I think the conventional wisdom now is, look, I'm not going to tell someone they were traumatized if they don't tell me, right? So I'm not going to go digging for something. I wait for someone to bring it to me. And sometimes people don't want to talk about their trauma, and that's okay too. I'm going to encourage people, but I'm not going to coerce anyone. I'm not going to push anyone to talk about something they are not ready to talk about. So I think that just general change in the philosophical stance of how we approach trauma victims, that in itself safeguards against a lot of those kind of debacles, right? Where people who are suggestible are having memories implanted. So that I think is very clear. I don't tell someone they're traumatized, they've got a trauma history when they don't volunteer. Now, the problem is this, though. The only caveat I will say is that PTSD has been described as a disorder of memory. There are a lot of paradoxical issues in memory when it comes to PTSD, and I go into it in a lot of length in the book. And that's what causes some of the confusion. And so in my mind, it is not unusual for me to meet people who look like they had a trauma history. They behave, the way they navigate the world, they navigate it like someone who has a trauma history. They may not be aware of a trauma history because a lot of times, especially in situations of severe childhood abuse, children often dissociate, right? They cut off, to escape the harshness of the situation they're in, they will dissociate to survive that abuse. So they may not have a conscious memory of the trauma, but that doesn't mean they're not behaving like someone who has a trauma history. So that's obviously a very tricky situation. And what I try to do then is I just focus on the symptoms. Again, I'm not going to tell someone that they were traumatized when they're not volunteering it. So then we focus on the symptoms.
Right. Yeah, this brings to mind that documentary film Leaving Neverland about the Michael Jackson story. And those two young men now, they're, I guess, in their late 20s. They were boys, like 7 and 8 years old when they went there. And yeah, clearly Michael Jackson was having sex with these boys. That's pedophilia. But to hear them talk about it, like at the time, maybe they just didn't have the language or even the cognition of what was happening to them. But they describe him as he was super loving. He was so caring for me, and it was a warm environment. I loved being there, and only later did they kind of figure out, oh, this was actually not good. Yeah. So that kind of brings to mind, to what extent does society say, you know what, that's a really bad thing. Oh, it's a really bad thing. I better be traumatized. Or is it really traumatic and they don't even know it because they don't have the language or even concepts, symbols to put in there and call it that and realize what it is?
Well, but I think the points that you're making really illustrate why children are just so vulnerable. When your brain is still growing, when your body is still growing, when your sense of self, your emotional sense, when that is still all developing and growing as it is in children. And these were really young children, like I think 5 and 7, 9. Do you know what I mean? Yeah. Children are uniquely vulnerable to trauma. We like to think that children are resilient just by virtue of being resilient, but they are not. Right. There's periods in a child's life where they are very vulnerable. And you bring up this good point. A lot of times when you have someone who is a predator, they're seductive.
Right.
It doesn't feel like abuse.
Particularly if you're Michael Jackson and you're the world's most famous person.
Well, the power differential is something that I feel like is worth commenting on.
Yeah.
That, Whenever there's a power differential in any relationship between a doctor and a patient, between a movie star and a fan, or a politician and a member of whenever there is a power differential, there is a potential for abuse.
Mm-hmm.
Period. And so I think that is an example of how abuse can feel like not abuse at that time to the victim. But as that victim grows and is no longer maybe beholden to that person in the same way, or that person or this victim grows, finds their own voice, has their own experiences, that story can shift. And so that's why a lot of times, unfortunately, victims of sexual abuse, they're not believed because their story shifts all the time.
Right.
But that's the very nature of traumatic memories. It shifts all the time. Maybe as children, these boys, they dissociated from those memories as a way to cope with their situation. Their physical survival was somewhat dependent on these other people.
Right.
So they had to find a way to survive, so they dissociate. But then it's only as adults that these memories start coming back. And I think one thing that came up in these stories was it was only when they become parents themselves that and this happens all the time with people who've been abused as kids, it's only when they become parents themselves, because becoming a parent yourself triggers you, right? You're around children all the time, and it triggers you and takes you back. And it's only then that people start often to deal with those memories. But I think the take home, there needs to be a public health message here. And I think the good news is I do think the societal awareness about sexual abuse of children, like you look at the scandal in the Catholic church, I do think the mental health literacy about sexual abuse has gone up. I feel like in the last 20 years of me being a doctor, I think parents are a lot more savvy, a lot more clued in, a lot less trusting, a lot less skeptical. But this is good, because then you're more likely to intervene or not believe someone or proactively prevent it. And that is the best thing you can do to prevent PTSD, right? I mean, if we got rid of child abuse, I think we'd get rid of, 60% of the PTSD problem.
Right.
So I think in that sense, just elevating public mental health literacy about how these things happen, about how someone can seem like the most nice person in the world, the most loving person in the world. But you know what? You need to be skeptical of people who are too nice.
Well, that was the other amazing thing that came out of that documentary film was they interviewed the parents and they just seemed clueless. Well, it's Michael Jackson. Oh, wow. Yeah. Like you're dropping your kid off there for 3 days and there's no one else around. And okay. So
it's seductive and it's hypnotizing, and but we have to be wary, we have to be cautious, we have to be skeptical.
Same thing with parents with their local priest, say a century ago or half a century ago. It just never occurred to them that this person in power would do this to my child. Yes. Well, that's become pretty evident now that's a real problem. I do wonder. I don't know if you give much thought to this. Are pedophile or pedophilic tendency young men migrating, self-selecting into the priesthood because there's an available targets there, or did they become like that after they get there and they can't have sex, the celibacy business and all that, and that's the only option to them? Sort of like sex in male jails. They're not homosexuals; they just have no other options, or some combination thereof. I don't really know. I'm not sure I can really think of any data or speak to the specifics. To me, I kind of have this blanket rule that wherever there is a power differential, predators will always be attracted to that. So, you take the case of the doctor for the gymnasts. Oh, yeah.
Right? Wherever there is a power differential, I think predators are attracted to those situations. And I think all we can do is be aware of relationships where there is the power. I mean, even the whole Me Too movement, what was that? A lot of times there was someone who had more power over the other person. Yeah. So they were able to harass them and get away with it. So I think the take-home message is whenever there's a power differential, you have to expect that someone may try to abuse that. And what can you do to arm yourself against that and defend against that and to be aware of that? So to me, I think I do spend a lot of time thinking about these kind of scandals. And to me, that's the crux of it, the power differential.
Yeah, I think you're right, totally. And that's what all the training programs emphasize. Since I'm in academia, I get everybody at Chapman University, where I teach, every 2 years we have to take the online program on sexual stuff and discrimination and all that stuff. And now they have it set up where you can't skip ahead and do other work while the thing, because they time it with each unit. So it's like, all right, I'm going to just grind through each of these scenarios. Yeah. And they're almost hilarious where they try to make them sort of politically correct. Like it's a female professor wanting to have sex with the young male students. Like, that happens a lot. Yeah. Anyway, but now, I mean, it's pretty clear since really the late 90s, I would say, that you just do not sleep around with the students. Don't ever do it. Don't even think about it. And I know corporations are doing this. If there's any power differential, you just do not date. There's no dating, sleeping around, none of that stuff. Right. And yet sometimes this stuff still goes on. And when these stories break, I'm like, what were you thinking, dude? You've had the same training programs that everyone else has had where they make it clear you can't do it. Maybe they just can't help themselves. I don't know. Yeah, well, we are not sure if the training programs prevent. I don't think we have the data to show if the training programs actually prevent anything. I think the organizations feel better because they've covered themselves. Oh, yeah, I see. Legally, they're covered. I trained him, Right. I think it speaks to the unconscious mind. I think, people, regardless, they can say one thing in some setting, but do something totally different, and they're almost compartmentalizing it, But I think it speaks to the power of reenactment. I mean, reenactment is a psychological phenomenon that's really at the core of a lot of PTSD and a lot of trauma, where on some unconscious level, you are just driven to reenact something from your prior life, whether it be an abusive situation, whether you be the aggressor in a traumatizing situation or you be the victim in a traumatizing situation. So it's a troubling thing, but I do, again, like I say, I think just by elevating the public dialogue about it, the fact that you say even in your profession alone, a lot of people understand why this is something that is harmful to students. Right. Just that in itself is a good thing. We cannot deny that is not a good thing. Is it going to get rid of professors who predators with their students? No, it's not. We need better ways at weeding out the bad apples, but I think the elevated literacy, because then I think people are more aware too. So if you see suspicious activity, you're probably going to be more likely to not turn a blind eye and maybe intervene, So I think overall it's good, but this is not going to stop. I don't think, as long as there's human nature, I don't think this is going to stop. I would be amazed if the Hollywood casting couch doesn't end. I mean, if anybody tries to pull that again, my God, the risks are so high. Particularly for the studios, I'm guessing they have massive training programs now to cover themselves. Right. I bet. Well, Shaili, we've been going for over an hour. I know you're busy. You got to get back to your patients and so on. Thanks again for your work. I mean, really, it's super important. I hope this is just the beginning of a national conversation that we can all just wrap our minds around this problem and do something with it. And I hope the healthcare system changes to be more accommodating for that. So thank you for your work. Thank you for having me on. It's been a pleasure, an absolute honor to talk to you.